It's my pleasure now to introduce to you somebody that you saw on one of those pictures earlier, a 2020 laureate of the Canadian Medical Hall of Fame, and the Professor Emeritus of Medical Education, Medicine, and Pharmacology right there at Dalhousie University, Dr. Jean Gray. Jean, I am going to turn it over to you.
Thank you very much, Lisa. When I was a teenager, I sort of took things very much for granted, including the teachers that I worked with, the actions of my parents, and so on. And gratitude was not one of my better virtues. Ironically, this all changed probably about 30 odd years ago when I got a surprise email from an individual I didn't know who identified himself as being the nephew of one of my teachers many years ago. I was a bit shocked and wasn't quite sure if this was a scam or not, but I responded, and I was glad I did, because the teacher had been a nun, so I obviously didn't recognize the name that he gave me. But then he told me what her religious name had been, and I recognized it right away. And he pointed out to me that she'd been living in a nursing home. She was now very elderly. She had severe rheumatoid arthritis, and she wanted to get in touch with me. So I gave him my mailing address, and a few weeks later, I received a letter in very frail handwriting in which she thanked me for being one of her better students. I don't know if she ever contacted anyone else, but it was a rather intriguing experience because I had no anticipation that I was going to ever hear from her. And it made me suddenly realize that I don't think I ever thanked her for being a good student. And even more importantly, when I'd gotten into university and I had some really excellent, absolutely superb teachers there,
Don't worry, I can hear you, Jean.
That's okay. I'm sorry. I was seeing those messages at the bottom.
No, someone's taking care of it. It's just that person's audio.
Okay, thank you. Anyway, when I got to university and had some absolutely superb teachers there, I had never, ever thanked them for the skills and the knowledge that they had imparted to me. So late in life, I suddenly developed an attitude of gratitude and began paying attention to thanking everybody that had really played a major role in my getting to where I am today. Some of them are actually here on the screen, people like Dr. Anderson, who's going to speak in just a minute. And I think what I'm trying to say is that I think as you look back on your careers in years to come, think about the teachers that made a big difference for you. Think about the friends and colleagues who supported you during times that were really hard, and just say a word of thank you, or write a word of thank you if that's the only way to get in touch, just so that they know that you appreciate what role they played in helping you to get where you are today. And with that, I'm going to take my own advice and thank the staff of the Canadian Medical Hall of Fame, Dr. Noni McDonald, who's going to give you a presentation shortly, and Dr. David Anderson, who's the Dean of Medicine at Dal, for all that they have done in helping me be where I am today. Thank you, and back to you, Lisa.
Thank you. Thank you, Dr. Gray. That was, truer words were never spoken. That's some great advice, I think, to students you know, gratitude is an important thing that sometimes we overlook. So I appreciate you taking the time to share those thoughts and to be with us today. You can see Dr. Gray's own tribute video on our website, everybody. I think you'll love it. It's worth the watch, and I encourage you to check it out. I'm very pleased as well that joining us today is the Dean of the Faculty of Medicine. Here to welcome you on behalf of Dalhousie University is Dr. David Anderson.
Thanks very much, Lisa, and good morning, everyone. So as Lisa has said, I'm David Anderson, and on behalf of Dalhousie University and our Faculty of Medicine, I'm really pleased to welcome you to the 12th Annual Canadian Medical Hall of Fame Discovery Days. And unfortunately, the second one of these events we've had to do virtually at Dalhousie University. Look forward to seeing everyone in person soon. I would like to recognize that Dalhousie University is located in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq. We are all treaty people. We also recognize the histories, contributions, and legacies of the African Nova Scotian people who have been here for over 400 years. I'd like to thank and congratulate our 2020 Canadian Hall of Fame inductee and Professor Emeritus of Medical Education, Medicine, and Pharmacology at Dalhousie, Dr. Jean Gray, for being with us this morning and sharing her message. As Dean of the Faculty of Medicine, one really important aspect of my job is to recruit excellent researchers and physicians to come and work here at Dalhousie. So I'm really excited to have the opportunity to speak with aspiring healthcare professionals and researchers such as yourselves before you embark on your post-secondary education and careers. Health researchers at Dalhousie are consistently finding better ways to prevent, treat, diagnose a wide range of diseases that are common in the maritime provinces, from cancer and dementia to heart disease and stroke. Importantly, we're also doing much research into the prevention, diagnosis, and management of COVID-19. Nothing has been more impactful in our world over the last 18 months than the tremendous benefits of vaccine research in this era of COVID-19. Such opportunities to be involved with important health research will be available to you as you move forward with your education following high school. So we're thrilled to welcome you virtually to Dalhousie today. You're going to have a great day of presentations and workshops ahead of you, and I hope I have the chance to work with some of you in the future. I want to thank again the Canadian Medical Hall of Fame for organizing this really important event. So it's now my great pleasure to introduce our keynote speaker, Dr. Noni McDonald. Dr. McDonald has long been an advocate for and a leader in child and youth health, locally and nationally in Canada, and for over 20 years on the global scale. She's a pioneer in the medical community in Canada and internationally. She was the first pediatrician in Canada who was certified in a special field of infectious diseases by the Royal College of Physicians and Surgeons. She founded the Division of Infectious Diseases at the University of Ottawa and led the Pediatric Infectious Disease Service at the Children's Hospital in Eastern Ontario in Ottawa, serving as chief until 1999. It was then that Dr. McDonald moved to Halifax to become the first woman in Canada to hold the position of Dean of a Faculty of Medicine when she took this post at Dalhousie University. Following her deanship, she was a co-founder of the Canadian Centre for Vaccinology, where she is still an active member. Dr. McDonald has had an incredible career. She has over 400 publications and was the founding editor-in-chief of the journal Paediatrics and Child Health from 1996 to 2016, the first Canadian pediatric journal. She has been a consultant and advisor to the World Health Organization for over 20 years, now serving on the Strategic Advisory Committee on Immunization, one of 15 people who provide major advice to the World Health Organization on immunization. In 2008, she co-funded and founded MicroResearch in Eastern Africa, a program that builds community capacity so that local healthcare providers can solve local health problems. This program has been so successful in Africa that it's now being used in Nova Scotia to serve communities across the province. Among her many honors, Dr. McDonald was named to the Order of Nova Scotia in 2019 and the Order of Canada in 2020. It's now my great pleasure to welcome Dr. Noni McDonald to be our keynote lecturer today. Dr. McDonald.
Thanks, David. I'm just bringing my screen up and hopefully I've done it right and it'll all
Yeah.
come up.
Yep, it's
Okay.
all good.
All
We're seeing
right.
your slides.
Great. Okay, we'll begin. So as David said, I just wanted to acknowledge that we are on Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people, and also very much appreciate all the contributions that African Nova Scotians have given to this region and this province in particular. So I want to talk to you about what affects our health. And I think, you know, if you'd asked me when I was a teenager, I wouldn't have thought about it as broadly as shown in this spread here. It's not just about the healthcare services, it's about all those other factors around us, water and sanitation, what our jobs are, what our education is, what our housing is, how accessible is food and nutrition to us. So let's look a little bit about what's that impact been on Canada and our health. So the Commerce Board of Canada report card on health compared to other countries, we were ranked 10, okay? And we got a B, not an A. And Nova Scotia got a D, and Newfoundland and Labrador got a D minus. So what's going on here? Well, the Fraser Institute in 2020 said, you know, Canada spends a huge amount of our gross domestic product, almost more than any other OECD country, high income country that we are like. Yet we have fewer acute care beds per thousand, fewer physicians per thousand, fewer psychiatric beds per thousand than all these other countries do. So what's actually going on here? Well, we actually have a fairly good life expectancy rate, although we're not in the top 10 globally of countries with the longest life expectancy rate. But for men in Canada in 2019, it was 80 years. For women, it was 84.1 years. But I stuck in some things here for us here in Atlantic Canada to note. You don't live as long as a man if you live in Newfoundland, Labrador. You don't live as long as a man in Nova Scotia or a woman in Nova Scotia. And again, if we lived in Nunavut, it would be even worse. So I want to go back, as Jean did, to where I came from. I was one of 5 children. I'm the second oldest. I'm the oldest girl. My next younger sister really has influenced why I do what I do. People used to think we were twins, even though I was 2 years older than her because I was never very big. But when she came to be 6, she stopped growing from when she was 6 till 8. And she spent most of her time in the Montreal Children's Hospital. And I am deeply grateful for Dr. Hillman, who was her pediatrician. That was around the time when thyroid replacement therapy was developed and cortisone came into being. Retrospectively, she probably had pan-hyperpituitary dysfunction following a viral infection. And he literally saved her life. She's now grown up and has kids and has had a fantastic adult career as well. But she inspired me. The other inspiration is that wheelchair right there. My very best friend, Kitty, who lived 3 doors down from me in Montreal, we went to kindergarten together. And then she didn't go to grade 1 with me, because she got polio and she spent most of that year in hospital. And then when I saw her again, when she would be going into grade 2, she was in a wheelchair with her braces, and we never got to go skating again or do many, many, many of the things that we used to do before that. I wanted to make a difference. I knew what these health conditions did for my sister and for Kitty. And I wanted to know why these things happened and what I could do to change things. So I decided I'd like to do my medical research. I was a little long way getting there. I did an undergraduate degree in microbiology and immunology, and then a graduate degree, also a master's in those. And then I was invited to go to medical school at the University of Ottawa, where I'd done my master's degree. You'll look at this picture I've circled myself in red, and you'll see a couple of things. First of all, there's not a ton of women there, although there were way more women in this class than there had been in the classes before, because this was one of the first classes that did not have a quota on the number of women who could get into the medical school. They kept women out once you got to be 10, for example. If there were 10 women at Queen's University, that was it. That's all that were allowed. But still, one of the other things in my class, although there's not that many women, There were almost no married women. I was it. There were almost no married men. There was one. And there was not very many women that were role models for us in the faculty on the clinical side. There were some that were in basic science, but not many that were clinicians. We were the first class that came through that didn't come directly out of high school into pre-med and then went to medical school. And what's very interesting about my class, we were a very different class because many of us came to this class with graduate degrees, and more than a third of them went on to do academic medicine. Now, as Dean Anderson said, I joined the faculty at the University of Ottawa in the Faculty of Medicine. That's where I started my academic career after I had completed all my training in pediatrics and infectious diseases. And one of the things I took on at the Children's Hospital of Eastern Ontario was clinic director for the cystic fibrosis clinic. And when I joined that clinic to lead it, it was a very depressing time. We had as many new diagnoses of cystic fibrosis in that clinic as we had deaths every year. Yep, these were children and adolescents dying of cystic fibrosis. We didn't have the new big changes that came with the genetic discovery of the gene in the late 1989, and we didn't have any of the new drugs that are available now that have changed everything because they've been able to correct the gene defect that causes the whole problem, that affects so many different organs in the children with cystic fibrosis. But we in our clinic said, we have to do something. It was so sad to just watch these kids die. So we said, what do we know? What do we know about nutrition? What do we know about how to best use the drugs that we have, the antibiotics, the nutritional support program? What could we do that could make a difference? And every year we'd look at the data for all of the kids that were in our clinic, and then we'd look at the literature and we'd move forward and we'd test one more new thing to see how we could make a difference. And over the years, we made a big difference. By the time I left that clinic in 1999, we'd had no deaths in children and young people, and the adult cystic fibrosis clinic was much better. Much bigger than our clinic was. It wasn't because of miraculous new drug. It wasn't a big discovery. It was that slow change and upward hill, doing the best we knew of everything that we knew had to be done, and then asking questions the whole time. We made a big difference. But I want you to understand all of the breadth of people involved in this. Yes, there were physicians, both pediatricians and subspecialists. There were nurses, social workers, pharmacists, physiotherapists, dietitians, respiratory therapists, the laboratory technicians, pulmonary therapy technicians, genetic counselors, and basic science researchers. Everybody contributing to make this difference. Now, when I went to the Faculty of Medicine at Dalhousie University, one of the things that I really was committed to do, which is why I actually, the first letter that I've had as an invite to come and think about the job, I actually threw it out. It was only the second letter when it was pretty clear somebody done some homework about who I was and what my background was. And they said a couple of things that really appealed to me. I said, well, you know, maybe I could do something about this. One of the things that had frustrated me about medical training and postgraduate training in medicine to be a surgeon or a family doctor or whatever was that all of this was done centrally at the main site where the medical schools were. And I thought this was not right because people didn't get a chance to see what healthcare looked like away from the big mothership. And because of that, when I came to be dean, put forward to the other, at that time, 15 other faculties of medicine, that we needed to do something about social accountability and distributed learning. This is now how it is. Every campus does this now. It's not new and unique like it was in 1999. And social accountability has now become an accreditation standard. And I'm really, really ever so pleased that that has happened, because we really should be accountable to the people who pay for our education. Yes, our tuitions are not low to be in medical school, but the actual cost of training to become a physician is huge. And it's the taxpayers who pay most of that. One of the other things that I did that I think point out yet another role for people that are in health and healthcare. It's about communications, about advocacy. As you can see here, this is an editorial that I wrote for the Canadian Medical Association Journal in 2007. I was deeply incensed because a little boy in Manitoba who was Indigenous from northern Manitoba, from Norway House, he had very serious medical conditions that precluded him from leaving the hospital unless he could have all of those things set up in his community. Everything, the healthcare, all the bits were all set up for him to go back to Norway House, except the provincial government and the federal government were arguing, if you can believe this, about who was going to pay for a special shower head adaptation for the bathroom in his house. And they argued and they argued and they argued. They argued long enough that he never got to go home. He died in Winnipeg in the hospital there. And this is just wrong. So I wrote an editorial about it. And that editorial actually got read into Hansard in Parliament, word for word. All of the parties there said, yeah, this is a problem. We should do something about it. But I hate to tell you, that was done in 2007. They are still arguing about this. It hasn't been completely fixed. And it still needs to be fixed. And I hope it will be eventually. Over the years for pediatrics and child health, we did advocacy many, many, many times for Indigenous children's health issues and for children of ethnic minorities. There are too many of our children in Canada who live in poverty, who don't have access to the medical needs that should be made available to them. And that was one of the things I tried to do with that journal over the years that I was editor. Now I want to shift to vaccines. As David said, I spend most of my time doing vaccinology now, the other time amount of time on MicroResearch. But I want to emphasize to you why immunization is so very important and why I've spent so much of my time in this area, all the way from basic science research all the way up to health policy, which is most of what I do now. What you may not know is between 1900 and 1999, i.e. last century, we gained in life expectancies almost 30 years, okay? But of those 30 years, 25 of those 30 years are due to only 3 things. Access to clean water and sanitation, and it's why it makes me so ill when I know we still have communities that don't have access to clean water and sanitation. That's number 1. Number 2 is immunization. Number 3 was discovery and availability of antibiotics. The other 5 years, that gave us 25 years of increased life survival. The other 5 years are all the other stuff we did in preventative care and acute care medicine. Not so much, guys. Vaccines and clean waters are the biggies. They make a huge difference. And you in your very own lifetime, like right now, can see the impact of this with the COVID vaccines. This is data from early October from the Public Health Agency of Canada, and you can see who's getting COVID right now. It's the people who haven't been vaccinated. Who's getting hospitalized because of COVID? It's the people who haven't been vaccinated. And who's dying because of COVID? It's the people who haven't been vaccinated. That's why we vaccinate. It makes a huge, huge difference. Makes a huge difference, not just on survival and hospitalization rates. This is the Sustainable Development Goals that were passed by the World Health Assembly in 2015. Every country around the world signed on to this, including Canada. You'll see there are 17 goals. We've got a couple that Canada's supposed to do this too, everybody else, but we're not a country with no poverty. We are not a country yet with zero hunger. We are not a country yet where everybody has access to quality education. There are many things we still need to do, including access to clean water and sanitation. But I want to emphasize here, of those 17 Sustainable Development Goals, 15 of them are influenced, 14 of them actually, are influenced by immunization. And some would argue 15 because the life below the sea, we now have some vaccines for fishes in fish aquaculture. Immunization is a big deal. The World Health Organization very much has recognized this, as has the World Health Assembly. And WHO was one of the partners that developed the Immunization Agenda 2030, which was a global strategy for immunization for the next decade. Its emphasis is on leaving no one behind, and immunization across the life course, not just for infants, but across the life course. This was approved by the World Health Assembly in 2020. And I'm deeply honored to have been part of the development of IA 2030. But I want you to understand the breadth of people involved in this: clinicians, epidemiologists, laboratory technicians, communication experts, technical writers, basic scientists, clinical and behavioral researchers, policy analysts, and I could go on and on. The breadth of what health means in terms of professions is huge. So even before COVID-19 came, we had people that were concerned about accepting vaccines, and it was called vaccine hesitancy. And in 2019, pre-COVID, WHO said this was one of the 10 threats to global health. So what is vaccine hesitancy? By definition, it's the delay in acceptance or refusal of vaccines despite the availability of vaccine services. It's complex, it's context specific, it varies across time, place, and vaccine, and it's influenced by a number of factors. At that time, they were lumped into what's called the 3 C's: convenience, how easy is it for you to get vaccine; complacency, how important do you see getting vaccines, or are other things in your life that are more important, so you just push it off; and confidence, how much do you trust the system. We know in Canada, vaccine hesitancy is about 10 to 20%. It doesn't mean that 10 to 20% aren't accepting the vaccines. They may be accepting it, but they still have some doubts or concerns. And we know that harsh, hardline vaccine deniers, nothing about vaccines is any good, is around less than 1.5% in general. Although I have to say they've been popping up like mad against COVID vaccines. So the decision to have a vaccine is very complex. It's based on your lived life experiences. You're strongly influenced by what we think others around us are doing or expecting us to do, our social networks. We may see causation in coincidences. The after it, therefore because of it, doesn't always tell you causality. And this is a big one. We see what we believe, rather believing what we see. And I'm going to emphasize that for you. If I'm telling you a fact that is congruent with your belief, you hear me. If I'm telling you a fact that isn't congruent with your belief, you don't even hear that fact. And what we as healthcare providers have to do is try to rewrap those facts so you can hear them. We as humans, we prefer anecdote and stories to data and evidence. And we pay much more attention to negative information. Negative information is much more scary and it sticks like glue, much better. That's why when somebody raises a safety concern about a vaccine, you hear that and it sticks much better than when you hear something positive about how well those vaccines are working. And that can undermine your trust in that vaccine and in those people speaking for that vaccine. And then the other issue, and COVID has certainly shown us that, access may be difficult, or it may be seen to be difficult, or when you show up, you may not be very much welcome there. And if that's so, you may not want to show up. So this just shows us about COVID and vaccines globally and where we are. This was done in mid-October, and you can see Canada was doing relatively well, but we still had a fair amount of disease going on, albeit not as bad as many other countries per million. So here's Newfoundland Labrador data for you. This was done November the 1st. You had almost 92% of the eligible people that had at least one dose, and about 85% had been fully vaccinated. You'd had a total of 15 deaths altogether. Here's the data for Nova Scotia. We had more than 7,400 cases. We had 101 deaths. But as you can see, if you look at from when vaccines were readily available, almost all of our cases were in the unvaccinated. Let's look at COVID deaths for a minute, though. Newfoundland, Labrador, 15 for 0.52 million people. That's 1 in 35,000. Pretty good. Nova Scotia, we're about 1 in 10,000. Canada, we're about 1 in 1,300. In the United States, it's 1 in 443 at that time, early November. Early November, it's worse now. I want you to understand that for the United States, COVID has probably decreased their life expectancy by 2 years. Vaccines really are important. And the majority of the people dying in the United States are people that were never immunized, just like in Canada. Okay. So what can we do about vaccine hesitancy and vaccine acceptance? Because if we've got the vaccine, but you're not taking it, we got a problem. And this was data from the Public Health Agency of Canada. And you can see we're doing pretty well globally compared to other countries, but we still have a range across the country of acceptance. And even within a country, within a province, there are variations on this. So what do we know about vaccine hesitancy and about the factors that affect it? Well, there have been a number of models and frameworks that have been put out. One of them was called the 3 C's model, as I spoke to you in 2014. Confidence, how much do you trust? Complacency, how important is this in your scale of things to do, or would you rather go and play hockey? Convenience, how easy is your access to this? How are you welcomed when you get there? And what are the psychological pieces around it? In 2016, another framework, the 5 A's, access, affordability, awareness, acceptance, and activation were put up. In 2018, they added 2 more C's to give us the 5 C's. Collective response, how much I care about caring for other people in my community. And calculation, engagement with other people to find information. Then the WHO put out one, the 4, what people think and feel, social process, motivations, and practical issues. But the problem for a lot of us when we look at this is it's like describing an elephant. And everybody sees it from a different view, but nobody's standing back to look at all of those factors that are affecting acceptance. So the Royal Society of Canada, the COVID-19 Vaccination Acceptance Working Group, put together a much more complex view of this with 4 domains that all work with each other. And I want you to know we put in politics. Okay, because you know it matters what the premier is saying or what the prime minister is saying or what the president of a country is saying. All right, they can affect people's choices, as well as those 4 domains of immunization, what healthcare workers say and do, what's happening to the people in the place and how they see vaccination and the system. There are also these overlying items, communities, education, infection control, and communications. I want to make one big point now that is really important when you're looking at one of the factors that has very much influenced COVID vaccine uptake that people had not really understood how important until it was done. So I want you to recognize the difference between inequality, which is unequal access to opportunities. Equality is evenly distributed tools, evenly distributed, versus equity, which is custom tools to fit so that you can actually get what you need so the actual access is possible. And justice is fixing the system so that this is possible. So we have a big problem in vaccine equity globally, as this one will show you. One of the goals globally is that we would get 40% of the entire population of the world immunized with at least 1 dose of vaccine by the end of this year. Not going to happen. As you can see, the red, those countries are not going to make it. As of September of this year, the end of September, Low-income countries, 3.5%. 3.5% had one dose of vaccine. 61% of those of us living in high-income countries, at least one dose of vaccine. It is not an equitable world out there. Here's an example of access and equity, again, here in Canada. This is a Dene elder from the Northwest Territories. And from his village, he had gone out to his trap lines because he lives off the land. He was 92, but he was functioning like your average 60-year-old man, okay? He was out on the trap lines when they flew in the vaccine to his village and carried out an immunization clinic. They did not check who was not in the village at that time. Do you think he had access when he was out on his trap line? No, he did not, of course. And when he came back in to the village, there was no vaccine. They then had a small youth fair in his village where kids came in from other communities, were flown in. He's a fly-in village. He got COVID and he died. He died not because he was anti-vax. He died because he didn't have access. Because access to immunization in Canada is not the same. It matters where you live. It matters what your background is. There's a whole lot of pieces that influence access. Now I want to focus on just two things. There are a number of things that we know from the literature, from research studies that have been done that influence vaccine uptake. I just want to focus on two in the time that I have left. One is how many of you out there really like to have needles? I expect hardly any, okay? I've never, when I've asked this and I could see people, has anybody put their hand up and said, I love needles, okay? Well, you know, at least 10 to 15% of adults actually fear needles, and about 4 to 5% even have a needle phobia. They just can't even get anywhere near where needles are. It's higher for children, and it's somewhere in between for adolescents like you, for young people. We have evidence-based guidelines on how to decrease pain with immunization. We know how to do this. Sadly, it's not done in every vaccination clinic, and it should be. There's a system called CARD, Comfort, Ask, Relax, and Distract, that puts into place all of the pieces that are needed. We also know that you need to decrease immunization stress-related responses. You do this by decreasing pain.
We're in a meeting with her.
Can you put on mute, please? Thank you. You need to decrease immunization stress-related responses. That's the fainting that happens. That's the headache and fatigue you may feel afterwards. And we know if you decrease pain, you can work with this and decrease this.
What?
The second area that I want to cover is the dis and misinformation. You know, WHO has called this the infodemic. There's been so much mis and disinformation, it's not funny. Misinformation is false information that's created, not with the intention of causing harm, but you perpetuate it by sending it along. Disinformation is false information that is deliberately created to cause harm. Why do they do this? They do it because they want to sell you something, economic gain, they want to make money, political gain, the cartoon shows you that one, and they want attention or prestige. It's only one of those three reasons why they're doing this. So if you go back into the anti-vax stuff that's come out for COVID, when they've tested it back, most of it comes from 10 people. 10 people. But boy, have they been able to spread this widely. And those 10 people are making money out of this big time. Does misinformation matter? This was a study that was recently published. It showed, it was done in the United Kingdom and in the USA. And what it showed was it decreased your intention if you were exposed to the specific piece of misinformation that they showed you versus the control group that were not exposed. 6.2% less people in the United Kingdom were going to accept vaccination and 6.4% less in the US. It matters. What can we do about it? Well, healthcare workers can be trained to inform their patients that you're going to hear misinformation and disinformation. Alert them that this stuff is coming at you and the techniques that are being used to con you. Fake experts, conspiracy, impossible expectations. Oh, that vaccine has to be 100% effective and safe. Listen, getting out of bed is not 100% safe. There's nothing we do that's 100% safe. Selectivity, let me just pick out this little piece of science and blow it way out of proportion and take it out of the context. And misrepresentation, false logic, and emotions. They're the same techniques they use over and over and over with misinformation and disinformation. Healthcare workers need to correct that information and put out what is correct. They need to be transparent, they need to be consistent, and they need to do it through official channels. There's a website you can go to, Science Up First, which is working very hard here in Canada, trying to refute misinformation and disinformation. I hope all of you who are listening will actually do this. This is the United Kingdom Bad News Game. It teaches you how to be a bad news expert and you win badges for being a bad person, for trolling and everything. It capitalizes on social media. And when you've done this video game, it's a video game. It only takes you 20 minutes and you will do well, but you will learn. And when you're learning, it helps to protect yourself against misinformation and disinformation. It's teaching you media literacy, critical skill thinking. Again, many different kinds of people went into developing this work. Last, I want to finish by saying our health is impacted by so many factors. So there's a wide range of areas that you can choose to work in if you really want to impact on health. You don't have to be an acute care provider. But whatever you do, I want you to focus on doing your job well, but also on finding solutions for the problems that you see, just like we did in the cystic fibrosis clinic. Never accept that what we do today is the only way or even the best way to go forward. Keep asking questions and answering them. Expect programs and policies to change as science evolves. Be open-minded and evidence science-based in your practice, regardless of the area of health that you're in, and care about what you're doing, because so many of us are really dependent on you doing your job really well. And you know what? You are going to make a difference. You are all of the tomorrows for healthcare, because all of us will eventually be gone. So thank you for the privilege of speaking to you today, and I hope you enjoy the rest of the conference.
Wow, thank you, Dr. McDonald. You have given everybody an awful lot to think about, but more importantly, I feel like there were some really empowering components to your message, directing them to the bad news game, encouraging the students here today to not just hear the information about why are there anti-vaxxers anyway, but what can they do about getting accurate information and being part of truth spreaders rather than fake news spreaders. So thank you so much. Your passion, you can feel it right across Zoom. I can only imagine what it would be like to be in the same room. Students, you just have a few minutes before you go off to your workshops. Please take a quick break or join the meetup and go back to the actual agendas to get a sense of where you're supposed to be next at 10 o'clock. Can't thank you enough, Dr. McDonald. Really appreciate you taking the time in what is obviously a very busy life. And with that, we'll let the kids go off to the rest of their day. Appreciate it very much.
My pleasure.
Take care, everyone.